Okay, why don't we get started? I'm Ik-Kyung from Massachusetts General Hospital, Boston. With me, Dr. Gary Mintz from New York. We have distinguished panelists, Dr. Jang-Ho, Jung-Min Ahn, and Collet, William Fearon, Seung-Ho 선생님, and Nils Johnson, Bon-Kwon 선생님, Takashi Kubo, Akiko, Maehara, and finally, Yoshiyasu Minami from Kitasato University. Without further ado, we will go ahead, start with the first speaker, Dr. Kang Do-Yoon, OCT versus IVUS, when, how, and why. Dr. Kang.
Thank you for your introduction. I'm Dr. Kang from Asan Medical Center. I will talk about the OCT versus IVUS for PCI guidance. We have two major intracoronary imaging devices. One is OCT, and two is the intravascular ultrasound. And recent guideline recommends IVUS as a 2A recommendation for left main or complex coronary artery stenting, and OCT as a reasonable alternative, except in ostial left main disease. It's the same 2A recommendation. And stent failure patient, IVUS or OCT is a reasonable approach as a 2A recommendation. This is the very good paper from the Dr. Maehara, and the OCT used the near infrared light, and IVUS used ultrasound, so there is inherent difference between two methods. The OCT has a better actual resolution, but needs the blood clearance, usually with the contrast agent. And the IVUS, because the actual resolution is good, the plaque burden and vessel or the aortic ostial visualization is available. And in vivo comparison showed a little bit larger lumen area in IVUS, but in other study it was similar. Then, when is the OCT would be better? So it has the better spatial resolution in Illumian 3 study that detected more acute complications like dissection or malopposition or tissue protrusion after stenting. And now it is available with the faster image acquisition with the Angio co-registration. So it's very useful to evaluate the landing zone with the Angio and OCT image. And the visualization of the calcium is available with the thickness evaluation. IVUS can evaluate the arc and length of the stent at the length of the calcium, and OCT can also visualize the thickness and area volume of the calcification. This is the comparative image of the IVUS and OCT in the same calcification. OCT is fast and can clearly visualize the calcification, including the thickness. Then IVUS, the thick calcification, we cannot see the backward. And the visualization of the in-stenotic stenosis, especially in calcified neoatherosclerosis, is very good with the OCT. It can discriminate the calcium and neointima and stent. And the OCT in ISR can visualize in more detail about the stent stroke coverage and discrimination between stent and calcification. And after the ballooning, in-stent dissection or edge problem or other complication is easily seen. And especially for the bioresorbable scaffold evaluation, OCT is very good. This is an example of the ISR, the stent, and because of the undilated lesion, we performed the LOTA. And in IVUS, the lesion was not well visible, but in OCT, we could clearly visualize the breakage of the calcification and lesions. And also, the 3D the imaging with the delicate bifurcation PCI is available, and many operators are using for the optimal wiring and the kissing balloon. Then OCT angiography co-registration is very good, and with the faster imaging acquisition in long region is very useful. And where visualize the calcium or in-stent neoatherosclerosis with the delicate 3D view is available. But sometimes it cannot visualize the reference vessel, and poor visualization of the ostium is the limit of the OCT. And in this contrast or dextran to clear the blood in the vessel. And how about the IVUS? Thank you for the Gary Mintz slide. There are very large amount of the scientific evidence, especially for the IVUS guided PCI. And also in left main PCI, even 10-year follow-up outcome data is available with the IVUS guidance compared to angiography. And this is our the 10 years ago data that showed 5, 6, 7, 8 more than the 5, 6, 7, 8 minimal stent area in left main PCI showed good clinical outcome. And recently we revised the numbers with the only crush techniques, and over 6, 8 at the circumflex and LAD ostium. The patient with the LAD and circumflex under expansion showed large, higher degree of the major adverse cardiac event or all-cause death in 5-year follow-up. So the IVUS has the more stronger scientific evidence, especially in left main PCI. And also it can visualize better, especially for the ostium, because the OCT cannot systematically misses the first left main segment. And also the PCI for non-visualized vessel like CTO or no reflow phenomenon. And even I cannot see the distal vessel after ballooning. I can see vessel by IVUS and can treat with the measurement of the size of the vessel and stenting. And also the real-time guidance, especially for the CTO PCI, is a very strong point of the IVUS. You can see, and real-time guidance is available. And furthermore, minimal contrast procedure is available. This is an example with a biplane angiography with the minimal contrast. The patient creatinine was 7.5, and I checked the Angio, and the RCA circumflex was treated with the IVUS guidance. We checked I checked the landing zone with the IVUS and just implanted stent and optimized with the IVUS result. And 2-vessel PCI was done under 10 system contrast. And then IVUS would be better. It has a stronger evidence, and vessel size OCTR visualization is better. And visualize vessel even without flow and no contrast needed. But difficult evaluation of the thick calcium or instant atherosclerosis. So this is my thought. In simple lesion, similar. Left main or ostial lesion, IVUS would be better. And calcified lesion and instant restenosis, the OCT would be better. And in STEMI patient, to find erosion, OCT would be much better. And in shock or no reflow patient, IVUS without the contrast use would be better. In patients with the renal dysfunction or heart failure, IVUS would be better. Then there was 3 or 4 clinical trials that compared OCT versus IVUS. First is Illumian 3 trial. The primary endpoint of final post-PCI minimal stent area was non-inferior in OCT compared to IVUS. Second is opinion trial in Japan that compared OCT versus IVUS in 800 patients, also showed non-inferiority in target vessel failure at 12 months. The smaller another RCT in Japan showed similar non-inferior in segment MRA by OCT at 8 months. And because, however, there was some limitation of the relatively small number and complex lesion exclusion. So we performed the all-comer PCI OCTIVS trial comparing 2,000 patients by 1,000 versus 1,000 in all-comer PCI, and the primary result will be announced this year. However, what's really important is not OCT versus IVUS. The really important thing is to use any intravascular imaging for guiding PCI, especially in complex PCI. IVUS improved clinical outcomes in larger RCTs, IVUS XPL, and Ultimate randomized control trial, and the recent renovated complex PCI with the IVUS and OCT improved clinical outcomes in complex PCI compared to angiography-guided PCI. Furthermore, meta-analysis of the 10 RCTs showed clinical benefit of intravascular imaging devices compared to angiography-guided PCI. Because with intravascular imaging, I can implant a bigger stent with a higher pressure post-dilation, so get the bigger lumen area safely without complication. That small details make a big difference in clinical outcome. In conclusion, OCT versus IVUS, which is better? They are different with their own advantages and limitations. The OCTIVS trial will show the comparative effective and safety of the 2 imaging modality in all-comer PCI. And just remember to use intracoronary imaging in the complex PCI. It is the evidence-based approach for the best clinical outcome. Thank you for your attention.
Okay, we will have discussion session at the end, so we'll move on to the next. Dr. Jung-Min, it's a pleasure to introduce you, and how to use coronary CT imaging and physiology for multivessel disease. Jim.
Great. Thanks, Ik. Well, it's a pleasure to be here and pleasure to be here in person after a few years of this pandemic. And my biggest disclosure is that I can't use 8 minutes and tell you everything that CT can do and for multi-vessel interventions. But fortunately, there was a great article that was published by Professor Sorois last month in Neurointerventions, and I would just suggest that people read that. One thing that I think came out of this article is that I think we have to extend our view of coronary disease beyond binary measurements, right, of greater than, less than certain stenosis, or greater than or less than certain FFR value. And I'll just share with you over the course of the next 7 minutes or so, sort of what we've been working on in the last few years to try to help us really extend to the whole point of doing whole heart evaluation, to try to really glean all the information from everything related to coronary disease. That relates to things like stenosis and vascular morphology, to all of the atherosclerotic features, and also to coronary ischemia, and then show you some data that supports its diagnostic performance. I think what you see here are, on the right is a list of things that we found to be important for patient-centric outcomes in coronary disease. It turns out they all are pretty similar. So the things that predict major adverse cardiovascular events are also the things that predict ischemia. They're the things that predict rapid disease progression, complications and no reflow in the cath lab, and so on. The problem was that, I think it takes too long for us to do all of these kinds of things. So what we tried to do over the last few years is to try to automate this in an accurate way, and then also to translate it so that clinicians could use it easily in clinical practice. So let me just share how we do that. So what you see here looks like a workstation, and I think those who do CT, you tend to look at it in these curved multiplanary formats. You do visual semi-quantitative assessments of things, and then in order to do the research on it, to really try to understand sort of the vascular morphology, the ischemia, the atherosclerosis, you spend a lot of time doing manual measurements. And so what we did over the last few years is really to try to automate this. And so what you see here is an LAD, and you can obviously see the cross-sections coming through, but that all comes automatically now in a matter of minutes so that you can really do high-end characterization of coronary disease in a way that is meaningful. The problem with this is that, if you're not an imager, this is pretty useless to you, so it doesn't really add anything to your clinical practice. And so what we've tried to do is to enable research as well as facilitate this clinical application. And so what we do with all of these measurements is extract it, and then everything related to the coronary artery and everything related to coronary atherosclerosis is now curated for you on a per patient, a per vessel, per segment, even down to the lesion level, so that you can assess these lesions with great confidence and quantification. But the problem is that nobody wants to look at all these numbers either. And so what we then did was we tried to make a web-based platform that would be easy to use, that would summarize all of these quantitative features so that within just a simple picture and some infographics, you understand everything that's really going on in this patient related to atherosclerosis, to stenosis, to ischemia, to some scoring systems, and then also to try to make this interactive, right, so that you don't have to go down to radiology and find a CD, but rather you can just fully press on any place within the coronary tree and start to really understand things in greater detail. So if you press on this LAD lesion in the prox LAD, now you can go dive deep and relate everything that's going on related to the coronary atherosclerosis, the plaque morphologies, vascular remodeling, stenosis severity, minimum luminal diameters, and so on. And because it's interactive, the vessels have been laid out for you so that now you can see the targets that you're going. And if you aren't familiar with CT, the computer will automatically point arrows to exactly where you should be looking so that you can really dive deep into the visualization on a patient segment and vessel territory interrogation. Once you do that, if you want to start now really understanding coronary stenosis and vascular morphology better, you can click on a deeper dive tab, and then you can see the number of severe and moderate stenoses. By vascular territory, you can see the numbers of mild, moderate, severe, and chronic total occlusions, and the computer will just tell you exactly where they are, how many lesions there are. Or you can look at an overall bird's eye picture of all 18 coronary artery segments, the relative percent diameter narrowing, the minimum luminal diameters, the normal reference diameters, and similar to the other page before, it's fully interactive so that you can just click on every tab or any tab, and then what you can start to see is all of the measures of stenosis, the normal reference diameter, which can help you with stent sizing, the plaque length, which can help you with stent length, and then it's also fully interactive, so you can spin around in 360 degrees and do sub-millimeter mapping to make sure that you understand the lesions that you're trying to revascularize. Once you're done with the stenosis measurements, you can also start to look at the plaques that cause the stenosis, right, with a really heavy emphasis on atherosclerosis and the number of calcified and non-calcified lesions and the breakdown of that plaque. If you click this atherosclerosis tab, now you can see all of these measures around the type of atherosclerosis that's causing the stenosis that you're seeing within the lab. And I think that does have important implications on pre-procedural decision-making. For example, if you take these two LAD arteries and you start to look at these calciums, what you can see is these calcified plaques are extremely different. In fact, this one here is so bright, and this one's not that bright. And we had published a paper back in 2020 in JAMA Cardiology showing that these plaques that you see on the right, or on the left rather, these very bright, dense calcified plaques are actually protected against myocardial infarction, while these over on the right are not. I think that because you can start to get the geometry, and not only the geometry, but the density of the plaque, you can imagine that if you had somebody with a subtotal occlusion, that you were thinking about doing intravascular lithotripsy versus rotational atherectomy, and how that can influence whether or not you can find a portion of this lesion that has like a weak spot that maybe you'd hyperinflate a balloon and start there with your procedure to try to help facilitate it. And then I think you can get into a lot of these clever sort of computational things where you look at radiomics and start to develop machine learning models to help you understand your pre-procedural decision-making even better. And then in addition to that, because now all of this is automated and in 3D, now you can start to dive deep in the kinds of lesions that typically cause peri-procedural complications in the cath lab, namely these low attenuation or low density non-calcified plaques, or the CT equivalents of the necrotic core. But what you're seeing here is a whole bunch of different things that we've never been able to measure because it's been so manual in the past, and now we're going to be able to look at this. And then now if you have all the things related to vascular morphology, to atherosclerosis, and what you can do is you can start to understand this vessel, and devoid of any assumptions, you can throw it into a mathematical algorithm and have that algorithm tell you whether or not this coronary vessel exhibits ischemia or not. That's this halo concept right here. You can see all of the haloed vessels are indeed ischemic. And if you wanted to dive deeper, what I like about this approach is that it tells you not only that there's ischemia, but why there's ischemia, where you can start to look across the entire length of the vessel. You can look at every single lesion that may contribute to the ischemia along that length, and then you can see which are revasculable targets, whether it's because there's a high-grade coronary stenosis with high-risk plaque features or not. And so here's the first lesion in this LAD. You can see here's the second lesion in this LAD. And now you can do whole vessel mapping of every lesion within the vessel. If you look at the diagnostic performance of this approach, whether for measures of stenosis or atherosclerosis, in all of these 5 multi-center clinical trials, what you can see tested against invasive angiography, expert readers, fractional flow reserve, NIRS or IVUS, that it generally performs pretty high compared to these gold standards. There is another trial that Dr. Mintz and Dr. Lansky at Yale are currently doing the core lab analysis for OCT, so that should be coming out pretty soon. And then if you take all of those things and then plug them into a machine learned algorithm to determine coronary ischemia, what you can see is in this Credence trial as well as the Pacific trial, that for measures of accuracy as well as for measures of discrimination, that this approach does seem to be pretty good for determining coronary vessels that exhibit ischemia. So I think the future is pretty bright for using non-invasive imaging to plan for procedures prior to going into the cath lab. These AI-enabled tools now allow for true quantitative evaluation of most of the coronary disease features. The platform technology allows you to just log on to a website and start to use this clinically right before you head into the lab. And I think the performance of it is similar to most of the invasive gold standards that we've seen to date, and is superior to all of the other non-invasive methods that we have currently. And what I think what's doing mostly is really starting to help us understand the complexity of this disease process so that we can stop binarizing coronary disease and really extrapolate all of the important features that contribute to the success of a revascularization. Thank you very much.
Thanks, Jim. So now we're going to go to Fuwai Hospital in Beijing, China, to hear from Jubo on the future innovations in imaging and physiology, specifically angio-based FFR.
Thank you, Chairman. It's a pleasure honor to participate in TCTAP again. Today, my topic is future innovations in imaging and physiology, the angio-based FFR. Here's my disclosure. So the very first two publications in 2014 introduced the computed fractional flow reserve and virtual functional assessment index, which was a prototypes of the QFR and the VFFR respectively. Now today we have four systems available on the market, including QFR, FFR Angio, VFFR, and CAFFR. If you look at the publication indexed by Medline, articles focusing on geography-derived coronary physiology in the past decade are rapidly growing, a total of 317 publications until March 21st this year. The majority was related to the QFR. This slide summarizes the online diagnostic accurate performance from major prospective clinical study by using wire-based FFR as a reference standard. And all these four systems demonstrated excellent accuracy, sensitivity, and specificity. The next generation of QFR, so-called mu QFR, provide more accurate reconstruction of vessel size based on Murray bifurcation fraction law. Can support single projection for rapid calculation and powered by artificial intelligence, and show high diagnostic accuracy of 93% when compared with FFR. What about the angiography-derived index of microcirculatory resistance? Until now, a study has been performed focusing on direct comparison between invasive IMR and angiography-derived IMR. All these studies show high diagnostic accuracy of angiography-derived IMR compared with IMR. However, we believe further prospective study are needed to investigate its prognostic value and whether this information could inform clinical decisions. So what about randomized clinical evidence? Phase 3 China is the first randomized trial comparing QFR guidance versus standard angiography guidance for lesion selection of PCI. And the AQVA trial comparing virtual PCI versus angiography. And you can see many head-to-head randomized comparison, Phase 3 Europe, Japan, Pioneer 4, Fast 3 RIPCORD strategy, Flash FFR2 are ongoing. So in Phase 3 China, among patients undergoing PCI, QFR guided strategy of lesion selection actually improved 1-year clinical outcome compared with the standard angiography guidance. And the benefit of QFR guidance continue to accrue over time. And the 2-year risk of MACE was reduced by 34%, and the benefit was most pronounced among patients in whom QFR assessment adhered the planned revascularization strategy. And a sub-study from Phase 3 China demonstrated compared with the standard angiography-based lesion selection, and the QFR guidance consistently reduced the risk of 1-year MACE in both diabetic or non-diabetic patients, a similar relative risk reduction. Another interesting publication last year in JACC intervention focusing on functionally complete revascularization. And in patients achieving functional complete revascularization after PCI, were associated with markedly lower 1-year rate of MACE, 5.1% versus 19.7%. And the QFR guidance can improve the likelihood of achieving FCR and improve the one-year clinical outcome in patients with both FCR and functional incomplete revascularization. So in the AQVA trial and the PCI guided by virtual standing, a 300 patient were randomized 1-to-1 to receive either QFR-based virtual PCI or angiography-based PCI. And the trial demonstrated a superiority of QFR-based virtual standing over angiography-based PCI with regard to the post-PCI optimal physiological result, which was defined as post-PCI QFR greater than or equal to 0.90. I believe this is a very promising approach in the future. Obviously, a large-scale outcome randomized trial needed. So phase 3, Europe, Japan is the first head-to-head randomized trial comparing QFR-based diagnosis strategy with FFR-based diagnosis strategy in 2,000 patients and for intermediate coronary stenosis. We are very much looking forward to the primary endpoint report of the trial in the near future. So what about next step? We established a concept of functional and angiography-derived screen integration FAST technique, which is a combination of a new generation MuQFR and the computational real-world screen technique. Actually, many publications recently show a significant association between RWS and OCT detected plaque composition and vulnerability was confirmed, and importantly, phase 3 China post-hoc analysis, a recent publication in JACC, shows a greater predictive value of MuQFR plus RWS for 1 year adverse cardiac events. So the objective of our next phase randomized trial is to evaluate the strategy of FAST technique, MuQFR plus RWS optimized revascularization in a high-risk population with a STEMI and multivessel disease, compared with a standard treatment on long-term clinical outcome. So this is an overall design of the phase 5 AMI randomized trial. In brief, patients with STEMI and multivessel disease underwent successful primary PCI of the infarct-related artery and who had at least one non-carpal lesion with diameter stenosis between 50 to 90% in a non-infarct-related artery. 5,000 patients will be randomized to testing group MuQFR plus RWS guided strategy or control group standard treatment strategy. So the study has powered a primary endpoint of MACE and the major secondary endpoint of cardiovascular death and MI with event-driven design. So a lot of data, a lot of randomized trial are ongoing. So we believe this is a future innovation in imaging and physiology and geography-based FFR will come to our daily practice and play an important role in the future. Thank you very much for your attention.
So we're now going to hear from Bill Fearon, I guess, on true message from FAME3.
Thank you, Gary and Ik, and thank you, Dr. Park, and the organizers of TCTAP for the opportunity to speak about the true message of the FAME3 trial. I'd like to review the main results of the FAME3 trial briefly and then talk about 4 key messages. As a reminder, FAME3 was a multi-center trial including all comers with 3-vessel coronary disease not involving the left main, and patients were randomized in a 1-to-1 fashion to FFR-guided PCI with current generation DES or to CABG. The primary endpoint was 1-year incidence of death, MI, stroke, or repeat revascularization, and it was a non-inferiority design with a hazard ratio, a margin set at a hazard ratio of 1.65. These are the baseline characteristics, which were similar in the 2 arms and typical middle-aged men were the majority, about a third were diabetic, and 40% were presenting with ACS. The key procedural characteristic that I wanted to highlight was that these were relatively complex patients with a syntax score in the 26 range that was similar between the two groups. So the primary endpoint occurred in 6.9% of the bypass patients and 10.6% of the PCI arm. The hazard ratio was 1.5 with the upper bound of the 95% confidence interval at 2.2, so above the non-inferiority margin. So PCI was not found to be non-inferior based on our preset criterion. But that was the primary endpoint, but I think there are a number of key messages that we can still learn from this study. The first message is that compared with historical data, outcomes with both FFR-guided PCI with current generation DES and bypass surgery have improved significantly. When you compare FAME3 to the historical control, the syntax trial, you see that the patient characteristics were quite similar with similar age, risk factors, similar number of lesions, and syntax score. Yet when you look at the one-year outcomes, which were defined in a very similar fashion and included the same endpoints, death, MI, stroke, or repeat revascularization, here you see the rates in the syntax trial. When you look at FAME3, you see that both groups, the PCI arm and the bypass arm, performed better than the bypass arm in the syntax study. And the other thing that you notice is that the difference between PCI and bypass has narrowed compared with historical control. A second key message from FAME3 is that for any test, in particular, in this case, FFR, to have a positive impact on outcomes, it needs to be used in a population and or in a manner where it will impact decision-making. And if we look at in FAME3, FFR could only be measured in about 80% of patients, meaning that 20% of lesions, FFR played no role in decision-making. In those lesions where it was measured, it was negative in only about a quarter. And for reference, in studies of intermediate lesions, FFR is typically negative in 60 to 70% of those lesions. And one of the main benefits of FFR is deferring unnecessary PCI when FFR is negative. So if we look at outcomes based on the anatomic syntax score in FAME3, the patients with a low syntax score, FFR performed quite favorably, PCI performed quite favorably compared with CABG, whereas in the high syntax score, the reverse is true. And what you notice is that the percentage of lesions that had negative FFR values was higher in that low group, 30% versus only 17% in the high syntax score. So this raises the question of whether, when we look at the syntax score, are there patients who fall into that high group that actually have better outcomes, and can we identify them by calculating what we call the functional syntax score? And that is basically calculating the syntax score and then subtracting any lesions that have a negative FFR. And when we did that, we found that the percentage of patients with a low functional syntax score increased from 32% in the anatomic group to the functional group of about 50%. And the reason that's important is that when we look at the outcomes in those low functional syntax scores, so half the patients, they have very similar outcomes to the bypass group, whereas the high functional syntax group patients have a significantly higher event rate. Now, another question that comes up is, well, what about those deferred lesions in, say, the low functional syntax group? Are they going to come back to haunt you? But what we saw was that the MI rate in this about 600 deferred lesions was only 0.5% at 1 year, and the revascularization rate of those lesions was quite low as well. A third message from FAME3 that I wanted to highlight is that not all quote-unquote hard endpoints are really that hard. And in particular, I'm referring to the definition of procedural myocardial infarction. In FAME3, we elected to define it in the same way for bypass patients compared with PCI patients. That way, the clinical events committee could adjudicate in a blinded fashion. And the definition was a fairly strict one. You had to not only have biomarker elevation, but you had to have at least one of the following: either new Q waves, angiographic evidence of vessel loss or occlusion, or imaging evidence of loss of viable myocardium. And so there is another definition that's a more lenient one from Sky that's also been shown to be prognostically important after PCI. This one has two definitions, or two components to its definition. One is just a biomarker elevation, or the second component is a slightly lower biomarker elevation with new Q waves. So it's a little more inclusive of a definition. Now, when we look at in FAME3, using the FAME3 definition, you see that procedural MI was quite low and it was similar between the two groups. If we had applied the Sky definition, you see a dramatic increase in procedural MI, and in fact, a 4% increase in the bypass arm compared with the PCI arm. So if this definition had been used, you can see that it would have completely changed the interpretation of the FAME3 trial. And I think it just highlights the fragility of myocardial infarction as far as an endpoint, although many call it a hard endpoint. Now, the final message I wanted to convey was that because the overall event rate was fairly similar between the two groups, there was only a 3.7% absolute difference, and there was no difference in death or stroke. Other endpoints like quality of life and angina relief become important to both the patient and the physician. And when we looked at quality of life in FAME3, by 1 year it was similar between the two groups. And the trajectory of improvement, as you can imagine, was significantly better in the PCI arm because they had much better quality of life at 1 month compared with bypass. When we look at significant angina, defined as Canadian class 2 or greater, there was a similar rate at baseline, and fortunately, both groups had a dramatic reduction in significant angina, and at 1 year, there was no difference in the degree or the percentage of patients with class 2 or greater angina. So in conclusion, FAME3 has taught us a number of true messages. FFR-guided PCI did not meet the criterion for non-inferiority to CABG. Outcomes with both FFR-guided PCI and CABG are significantly improved when compared with historical data. In less complex disease, where measuring FFR can actually have an impact, FFR-guided PCI performed very favorably in comparison with CABG, and the functional syntax score identified half of the patients who benefit most from PCI. Endpoint definition, particularly procedural MI, clearly affects one's interpretation of FAME3. And finally, quality of life at 1 year is similar after FFR-guided PCI compared with CABG. Overall quality of life during the first year is better after PCI, and significant angina is infrequent and similar in both arms at 1 year. So what's next for FAME3? Well, Frederick Zimmerman will be presenting the 3-year follow-up as a late-breaking trial at EuroPCR in a few weeks, and this will be comparing the incidence of just death, MI, and stroke between the two arms. So stay tuned for those results. Thank you for your attention.
Okay, next speaker is Nico Pijls. He has very provocative title, Don't Mess Up, Critics on FAME3, Flower MI, Future, RIPCORD 2.
Thank you, Mr. Chairman. Ladies and gentlemen, it is indeed a very challenging title. I was asked to give some critics on a number of recently performed studies. These are my potential conflicts of interest. And this is a sentence from a book, The Structure of Scientific Revolutions, written by the American writer Thomas Kuhn in 1965. He said, philosophers of science have repeatedly demonstrated that more than one theoretical model can always be placed upon a given set of data. And that is indeed the case. If we write a study, there is often a conclusion in the study. We are often guided in a certain direction, but we should remain critical. And if we think about it, sometimes different conclusions can also be possible. The study I have to criticize will always be called a study, and the studies with which I'm comparing is called the comparator. Let's first go to the issue FFR-guided versus Angio-guided PCI in multivessel disease. The study to criticize is the future study. The comparator is a FAME. In both studies, the hypothesis was that FFR-guided PCI in multivessel disease is superior to standard Angio-guided PCI. Endpoints was about the same. The design were RCTs in all comers. However, in the future study on the right, actually less than 1 patient per center was included per month, so you can hardly call it an all-comer study. The population in the FAME study was higher than in the future study. Strong point is that in both studies, 95% was deaths. The weak point in the future study is that although it was the intention that the FFR and eventually PCI would be performed in the same stage as the diagnostic angio, in 96% of all patients, the FFR was performed at a later procedure. And in a number of these patients, that was even after 30 days. And these second catheterizations, just to measure FFR, were counted as events. In addition, there was a poor adherence to the study protocol, although the baseline characteristics in the FFR-guided and the angio-guided group were exactly the same. Also, the number of stents placed in both groups were the same. So what was the difference made by the FFR? It can only mean that FFR must often have been neglected. So in the future study, the poor guys who were randomized to FFR guidance not only had an extra invasive exam, but in addition, the information from that extra exam was not used properly. So it is not surprising that I found equipoise for FFR guidance versus standard guidance, and that is completely different in the FAME study, where FFR guidance was superior to angio guidance, as shown in this slide, both at 1 year, at 3 years, and at 5 years. In the FAME study, there was about 30% advantage for all different types of events, and that was significant, not only for MACE, but also for DAS and MI. The second issue to discuss is FFR guidance for quality of life and costs. That was the topic of the RIPCORD 2 study. There's the study, and the comparators here are not easily available because there are few studies who had this issue as primary endpoint, but it was a secondary endpoint in a number of other studies, all of the FAME studies and the IRIS registry. The hypothesis in the RIPCORD 2 study was that systematic use of FFR during angiography is superior to regular angio with respect to quality of life and costs at 1 year. In the FAME study, this was one of the secondary objectives. The design was in both a randomized controlled trial. The risk in the FAME study was moderate to high. The risk in the RIPCORD study was very low because it was mainly a diagnostic population with only 29% of the lesions FFR positive. And in fact, if just in one lesion there was a 30% stenosis, all arteries were measured. So many normal arteries were measured. And as Bill Fearon just a minute ago already mentioned, you can expect little gain from any diagnostic mean or any therapy if you apply it in a healthy artery. The outcome was, in the RIPCORD 2 study, that it was equipoise for FFR guidance versus standard angio guidance with respect to quality of life and costs. In the FAME study, that was completely different. Quality of life was better, and also the economics were better. This is a paper from Bill Fearon published in Circulation 10 years ago, and it shows very clearly the cost efficiency of an FFR-guided procedure. And in fact, the FAME study was one of those rare examples in today's medicine where a new method was not only better, but also more cost-effective. The next point is complete revascularization during STEMI, including the non-culprits, and then especially FFR guidance versus angio guidance. We have seen recently the Flower MI study addressing that topic, and we have to compare with the Compare Acute study and the Dynami study, both published a couple of years ago, and very recently the FRAME registry from Korea. If we look at the hypothesis in these studies, in all of them, that is that in PPCI for STEMI, FFR-guided complete revascularization of non-culprits is superior to angio-guided procedures. And it doesn't matter if that is all done within one procedure or if that the additional PCI is done within the same hospital stay. The primary endpoint is the same in both studies. Both studies are RCTs. The population was identical. There was a difference in the design. In the Compare Acute and the Dynami study, the randomization was performed before anatomy was known. In the Flower MI study, the randomization was performed after the anatomy was known. So that can induce some bias. And in addition, in the Flower MI, in 16% of all lesions, PCI was done without physiology. Nevertheless, Flower MI was a good study. I cannot find many points of criticism on that. And I found equipoise for FFR guidance versus angio guidance. That is in contrast to the Compare Acute and Dynami study and also that FRAME registry, where it was clearly better to have FFR guidance of the non-culprit lesions in STEMI. What is important is that both studies favor complete revascularization in STEMI, but as I mentioned, compare acute and NAMI and frame, favor use of FFR, where flower MI does not. Then the last issue, PCI versus CABG and 3-vessel disease. I have to criticize the FAME3 study, and of course the comparator here will be the good old syntax study. The hypothesis in the syntax study was that revascularization with DES in 3-vessel disease is non-inferior to bypass surgery. The hypothesis in FAME3 is that FFR-guided revascularization is non-inferior to bypass surgery. The primary endpoint is the same, the design is the same. I use here the syntax 3VD. Population were both at high risk, all comers, mostly DES, known really weak points. The outcomes in both studies was that CABG remains superior to PCI in multivessel disease and high syntax score, and that PCI is almost equivalent and lower medium syntax score. But there is an important difference between the studies, and that has already been mentioned by Bill Fearon a minute ago. If you look at the outcome data, there is a difference because the absolute numbers in FAME3 are much lower. On the left side, you see the MACA rate for PCI angio-guided, that's the blue column, and if you compare that to the outcome for the FFR-guided PCI group in FAME3, you see that MACA is almost decreased by 50%. And it is lower even than the CABG outcome in the syntax study. However, also the surgeons have done a lot of progress, fortunately I would say, and the event rate in the surgical group is very low in the FAME3 study. So although in both studies we have to conclude that in severe and complex 3-vessel disease, CABG is still superior, we see that in this slide, there is in the 10-year difference, using better stents and using FFR guidance, we have decreased the rate of MACA in the PCI group by using the FFR by at least 50%. And I think that is a very important message. At the end, I would like to say that indeed, there is always a possibility to put more than one theoretical model upon any given set of scientific data, but we have to realize that some data sets are stronger than others. Thank you for your attention.
Our last didactic presentation has to do with the low penetration of FFR, why and how to overcome, by Jung-Min Ahn.
Thank you. I'm Jung-Min Ahn from Assam Medical Center. My topic is not easy, very tough. Actually, the great doctor, Dr. Park, Dr. Gu in Korea cannot solve this problem. Actually, FFR or IFR guideline is 1A. Particularly, I liked this one, no benefit in patient with angiographical intermediate stenosis and FFR is negative. IFR negative, PCI should not be performed. I like this sentence. So based on the many data, many New England Journal of Medicine data, this guideline is one recommendation. So this is my thought. FFR or IFR, coronary physiology, it would be the minimum scientific or ethical safeguard to avoid the unnecessary PCI. So don't do PCI if FFR is negative or IFR is negative. So what is the advantage of coronary physiology based on our registry? So after FFR, routine FFR, stent number decreased. So stent number decreased and stent associated side complication also decreased, mostly due to the reduced periprocedural myocardial infarction, reduced repeat intervention. In addition, meta-analysis from FAME2 dynamic compared acute demonstration that FFR-guided PCI can reduce the risk of spontaneous myocardial infarction. Then lots of data, lots of very strong guideline why physicians didn't use FFR. So let's look at the other story, revascularization in stable angina. In Courage trial, 2,000 patients enrolled during the 7 years. PCI versus medical treatment, no difference. The spontaneous myocardial infarction, no difference. FAME2 trial, early termination, 800 patients enrolled up to 5 years, there's no difference, but the spontaneous myocardial infarction was reduced by PCI if FFR is positive, less than 0.8, or ischemia trial enrolled 5,000 patients. Revascularization cannot survive the patient, cannot improve the patient's survival up to 5 years. Crossover rate is 23, but reduced spontaneous myocardial infarction. In medication group, the 20% to 50% patients received the revascularization during the follow-up. In addition, spontaneous MI was consistently reduced by the PCI over medical treatment. Based on the ischemia trial, in medication group, 85% of patients no event. Atherosclerosis may be regressed and stabilized. Actually, majority of patients in medication groups no needed to further treatment. We know very well this is very strong evidence. But we have to think about some exclusion from the trial, some exclusion criteria, and left main and low ejection fraction was tested in previous study to show that the revascularization may improve the patient's survival. So, except the left main or low ejection fraction, in stable presentation, medication would be the default treatment for stable angina patient. Then, some studies show that after cardiac trial, orbital trial or another trial for stable angina, there is no change in the practice. Even after study publication, even the orbital trial centers, elective PCI numbers didn't decrease at all during for 13 years. I think the doctors, humans are like that. They didn't change easily. So previously, the United States published the appropriate PCI data from the NCDR registry showed that acute indication appropriated mostly, but non-acute indication, only 50% of procedure considered as appropriate. No angina, no risk ischemia, suboptimal medication. After publication of AUC criteria, NCDR registry showed that there has been a significant reduction in volume of non-acute PCI. It's a benefit of public reporting, I think. How about the FFR? In our centers, you may know that this graph, after publication of AM1 trial, in our centers, FFR penetration is about 50 to 60% before or during PCI. Even nowadays, annual use of pressure wire is more than 1,000 cases, pretty big numbers. So this is other countries' FFR use, FFR penetration. So before and after, most countries increased the use of FFR in their practice. I think gradually people are changing. It's nudging. So some guideline publication, not that change rapidly, but gradually people are changing their behavior, their practice. This is current status of SCAR registry. I was surprised that in 2016, more than 30% of PCI is a FFR-guided PCI. FFR-guided PCI show that the low rate of mortality. I was surprised too. VA registry, the bill, is it real? 2017, 70% of PCI is FFR-guided PCI, including your center. They have pretty old record, I think, highest FFR used nowadays. Yes, FFR-guided PCR is associated with lower mortality. Then, I'm living in Korea. We have a very great coronary physiology interventionist, Dr. Park, Dr. Gu. But in Korea, National Health Insurance Service database show that only 5% of PCI was done by the FFR-guided PCI. Yes, FFR-guided PCI is associated with lower mortality. More important things, One study evaluated what is studied before coronary angiogram. The rate of stress test is reduced, but the CT coronary angiogram significantly increased nowadays. So total study number is nowadays increased, but mostly due to CT, not stress test. So previously, Nils Johnson presented coronary psychology. What really works to increase penetration of FFR? Study just legal action, better wire, etc., etc. So how to overcome low penetration of FFR? I want to look at my neighbor countries. This is the penetration rate of Japan in market, rapidly increasing, 25% in 2017. They did some evaluation to compare the Japanese trend and United States trend. In Japanese trend, last 10 years, several years, Japanese trend showed that increased the elective PCI, but United States decreased elective PCI. So Japanese Ministry of Health, Labor and Welfare introduced a new reimbursement policy to reduce the unnecessary PCI. Ischemia was required, ischemia assessment, unless the stenosis was very tight. As far as I know, the less than 80% of diameter stenosis was required for planned PCI beginning in April 2018. This is the intervention, this comparison before policy and after policy, rapidly increased the ischemia assessment and rapidly decrease of number of planned PCI. So they said that although the database did not include the test result of ischemia assessment or detail of PCI associated complication, total number of planned PCI decreased without increase in overall mortality after implementation of a new reimbursement policy. This result say that potential clinical benefit because the policy change lead to a reduction in number of unnecessary PCI in patients with coronary artery disease. I think sometimes policy drive the change forward faster. I think policies including the insurance, legal action, public reporting, etc., etc. Thank you for your attention.
So because of time issues, we're now going to present the two cases. The first one by Myung-Ki Hong, imaging-guided PCI.
Thank you, Dr. Mintz. I'm going to talking about the imaging guide PCI. I have no disclosure in this presentation. The patient is 59 years, the male patient, and the patient complained of exertional chest pain, only had a history of hypertension. This is the angiogram of this patient. In the right coronary angiogram is quite a large size of the vessel, and there is some narrowing in the far distal part of the posterolateral branch. And the left coronary angiogram, when you look at the angio, the disease was beginning from the left main bifurcation, and they extend to the almost to be left medial AD, and the involvement of a big side branch vessel. Diagonal branch, first one, second one, and circumflex. And the other view, epicranial view, the disease segment was from the distal left main to the medial AD or proximal AD, involved a big side branch vessel. And the spider view more clearly showed that disease was involved in the proximal vessel, involved a big side branch vessel. So look at the angiogram. What is the best treatment of this patient for the PCI or bypass surgery? I think a bypass surgery is a good option for this kind of the patient, involvement of the big side branch vessel. So what is the best option, PCI or the bypass surgery? If the patient select the PCI, how many stent or do we use, or what kind of the PCI technique for the involvement of the side branch vessel? And what is the next step to determine the adequate treatment strategy? Therefore, anyhow, this patient select one of the PCI. We did a PCI. So anyhow, the first step is the intravascular imaging and the wiring in the circ and the second diagonal branch and the LAD and the dual IVUS. The IVUS image run shows fortunately, the ostium of the big side branch vessel was relatively preserved. And the middle LAD portion was the narrowing. This portion is not quite narrowed. When you look at the image in the IVUS image and the ostium of the second diagonal branch, first diagonal branch, and the circ was preserved. So after the imaging examination, we decide that just a simple crossover technique overall. Pre-dilator. The technique is quite simple. The lesson from the imaging and the simple technique and the pre-dilate the lesion and just a single stent based on the imaging, and the stent size was 3.5 and 36 from distal left main to the proximal LAD. And the post-stent imaging run shows some stent malposition and under-expansion. So based on IVUS run, I decided more high-pressure balloon dilation, 3.5, and the distal left main was 4.0, was the adjunctive high-pressure balloon. And this is the post-stent, post-high-pressure balloon, IVUS image run. The stent strut was well opposed and the stent was well expanded. And then this is the final angiogram. Hopefully, fortunately, the major side branch vessel was spared and the stent was well expanded. Actually, this case was done in 2018. And this is the objective study 3 years later. Fortunately, the MIBI scan shows no reversible defect in the myocardium. And currently, 2023, the patient is still symptom-free with medication, with aspirin, Lipitor, and carvedilol, and acetyl. Therefore, I'd like to conclude that just to use the imaging, whatever what it is IVUS or OCT without hesitation in complex disease. I think we fixed this patient with only single stent, even in the bypass candidate. Thank you for your attention.
The last case will be presented by Dr. Bon-Kwon, Physiology guided PCI.
Thank you, Professor Jang. So this is my disclosure. So this is a case with the 66-year-old gentleman with the recent aggravated angina, some risk factors, and no reasonable motion abnormality in echo. So it seems to be clear that this should be the culprit, but unfortunately the patient also has a multiple disease, left main ostium, LAD, ostium, and mid-LAD. So the question is how we can fix this lesion, image-based, physiology-based, or what will be the syntax score of this patient. So if I simply count the syntax score of this lesion, excluding the circumflex ostium, it's already 28. So you may consider bypass surgery, or you should prepare for the very complex PCI. But there's one way you can be a magician in the cath lab, is to use physiology in this case, which make 28 to 0. FFR 0.82, and now functional syntax score is 0. So that doesn't mean that you can fix this lesion only one stent, but at least I can start with focusing on the circumflex lesion. So for treating the circumflex lesion, one very important element may be whether this lesion touched the circumflex ostium or not. For that, I cannot use physiology, so I did the IVUS, and unfortunately, this lesion touched the circumflex ostium. That means I have to cover the left main. And in that perspective, the other very important element may be that left main ostium to define the proximal location of the stent. And interestingly, left main ostium is quite clear. So we know how to fix this lesion, left main to a circumflex stent and high pressure ballooning and left main past stenting. And then you have these images. And you know that during this stent implantation, I made some plaque shift and carina shift, and I have to remeasure the FFR if needed. And this was 0.73, so significant jail. We know if we leave this lesion untreated, the risk for future event increased more than 3 times than high FFR. So the next step will be the kilo stenting. So it's beyond the scope of this talk, so there should be several steps you should follow. But while doing this procedure, regardless of you're doing the image guidance, physiology guidance, when you do a complex left main stenting, experience is very important because it determines the patient mortality, and this result was recently reproduced by the large English data set. And this is final angiogram, but before you shooting the angiogram and satisfy with the angiographic results, but you have to remind that you cannot satisfy with the angiogram and recall these very beautiful images, image-based decision making. So on your left side, you're looking at the physiological approach algorithm endorsed by Korean, Japanese, European Bifurcation Club. This is physiological approach, but this endorses imaging more than physiology in case of tooth stenting. So before finishing the procedure, you have to check all these imaging results. So the second case is rather simple. 59-year-old male, recent angina, but the patient had a CKD. So it may be very straightforward and clear, but sometimes I need to do a physiology, so FFR 0.76, so this must be the culprit. But during this physiologic pullback recording, I can assess the hemodynamic significance as well as a physiologic lesion distribution, so that this curve is telling me that its function is significant and it's physiologically a very focal lesion. And the next will be how we fix this lesion, so that I may start with this lesion with this direct stenting or the trochoid balloon, so that during the procedure, while balloon angioplasty, as the pressure Y is there, so I can measure this pressure, which we call it a coronary wedge pressure, which is a 69, which is relatively high than usual, and which means that even this vessel is occluded, the risk of clinically significant MI is relatively low in this case. So the question is how we can reduce the contrast amount and also do a procedural evaluation with these images. And then this post-angioplasty FFR was 0.9. So in this expert consensus document for DCB implantation, successful angioplasty is defined by the angiography using no flow limiting dissection type C less and residual stenosis less than 30%, or you can use physiologic guidance FFR 0.8. However, the issue is the recoil. We know that after balloon angioplasty, recoil occurs, so you have to wait a little bit, taking another shot, or simply doing a physiology, because pressure wire is there, so what you need to do is just wait for a few seconds, and there's a physiology recoil happens. FFR has decreased from 0.9 to 0.86. The question is, what will happen 5 minutes later? So that another 5 minutes, and even without having extra contrast, the FFR 10 minutes later is exactly the same, 0.86, and delta FFR across the lesion is exactly the same. So that now I think that I can achieve the anatomically or at least functionally successful DCB angioplasty. So I started with the 0.76 functionally focal lesion, delta FFR 0.15, and now post-DCB, FFR has been increased to 0.9, leaving delta FFR across the lesion 0.04. So physiologic indices can help operators in PCI decision, procedure planning, and also the optimization. However, we have to understand when and how to use physiology as well as imaging or the combination. Therefore, it is very important to prioritize practice and education for physiology-guided PCI in patients with the complex coronary artery disease. Thank you very much for your kind attention.
Dr. Gu, you don't mind staying at the podium? So with your paper, physiology-guided PCI, do you ever use intravascular imaging guided? And if so, when? And if so, which one, IVUS or CT?
So I prefer IVUS for many reasons, and I do a lot of imaging, frankly speaking. And generally, I start with the physiology and planning with physiology. Then, when I do need to a complex stenting, I always do intravascular imaging.
But your paper suggested
So
physiology
which
guide,
paper?
New England Journal paper.
That has a little different nuances.
I mean, those are intermediate lesions.
Yeah.
And, you know, and the premise was interesting. If you only had one to select and treat intermediate lesions, which one wins? And the answer is yes. But those were not complex BCI lesions. No. So we have about 18 minutes for discussion, which is pretty good. I'm going to make one quick comment and then turn it open to the panels. There was a comment made at the first talk about OCT that has to be corrected. It was mentioned that if a patient has chronic kidney disease, you can use dextran instead of contrast. That's a mistake. The risk is from hyperosmolar media. So it's both contrast and dextran. There was one study that said dextran was safe, but none of those patients had chronic kidney disease. So if you have a patient with chronic kidney disease, you either use IVUS or you learn to do crystalloid or saline-based OCT. But you do not use dextran because it will cause renal failure just like contrast.
Totally agree. Only problem with saline is residence time is too short. So you have problem when you do a pullback.
Understood. But don't use dextran to prevent chronic kidney disease.
So can I ask one question regarding that program?
Sure.
So, you know, the many patients had a CKD, right? So is there any recommended cutoff level of the EGFR or creatinine level, you know, to use the OCT? For example, you know, the many patients with a severe carcinoid lesion also have the CKD frequently. So in that case, you know, how to choose IVUS or OCT? So is there?
I can answer. So very frankly, you know, totally objectively, there is no data to demonstrate OCT is superior to IVUS. So if you have any concern with renal dysfunction or CKD, AKI, then use IVUS.
I mean, the worst thing you can do is take somebody post-PCI and put them on dialysis.
I have a comment here. I'm trying to integrate all this that we have learned today, and it was very nice to see your case, Professor Koo, where you are actually looking at the FFR, but you're actually looking at the pullback and understanding that that is the lesion that you're actually targeting. What strikes me is that when you look at all this data that was beautifully presented by Nico and Bill, all these trials that we have done, that so-called FFR-guided PCI, are mainly being based on a single distal point, and there is not anymore the way we're using FFR today. Even in your recent trial, you're even using FFR to optimize. So you treat, you look for the gradient. If there's no gradient, there's no need to treat. Or what are you going to treat? So how, in your view, is this going to be integrated in the future when we think about trials using FFR or other physiological measures?
So Carlos, you're already integrating that concept using PPG index so that it's rather complicated. But I think that for decision making for PCI, we are doing a local treatment so that maybe the local physiological significance or hemodynamic change should be integrated in our decision making, or at least defining the revascularization strategy. So that the question is, which index should be the best? So that I'm now currently using the simplest one, delta FFR across the lesion. So you're proposing PPG, and some other are proposing DFFR DT, or some are proposing more complicated thing. but we need to define the simplest and most practical one, and also need more study to define how or which number should be the best in addition to the per-vessel FFR value.
Is Jung-Min still here?
Jung-Min, is he still here? No, so let me
No.
make one other comment.
Oh, so, what we do in clinical practice is, is a CAT-RAT3 or CAT-RAT4AB, that's all, really. And then we look at the individual vessel. The data that Jim demonstrated is massive for clinician. How can we integrate the massive data into our clinical practice?
Well, if I can speak from kind of a little bit about clearly, his initial presentation of the data is meant to minimize, and then you can go deeper if you want, but the assumption is most clinicians won't go deeper. They'll take what's presented as on the surface and just react to that. That's part of the goal, but then have the deeper data available either for cardiologists or for imaging people or for research purposes.
But in clinical practice, do you really need to go deeper?
No.
Yeah. Then it's relatively superficial.
Correct. Well, no, the presentation is actually fairly complicated because in one picture, you get a combination of physiology as well as anatomy distribution.
One very complicated thing in our presentation or reporting something or the decision making is that all things are continuous, but we want numbers, binary numbers, because we are planning to do a binary decision,
right? Yes,
So
no.
PCI or not. So there's no way to do a 30% probability of PCI. There's nothing like that. So, but the trick is that the CT has 100,000 data, long-term follow-up, repeat PCI. So they have a very deep and wide insight there. The question is, how can they transform it into a very simple reporting system? And Jim is very smart enough to do that, so that when I see his report there, coloring and the interactive way is enormous, so that I think in the future, that will change our practice and will be implied in our daily practice with the rather simple numbers or simple cutoffs.
With regards to Dr. Ahn's presentation, I'm often asked a similar question about imaging. We're the wrong people to ask because we believe in it. The people you need to ask are the people who are not using it and figure out why they're not. Now, there have been a couple of surveys of European and Japanese physicians in the imaging world. They're not very good. And it turns out they believe the data, but they're still not using it. So it sort of argues against more data driving decision-making or incorporation of these techniques.
Yeah, there is something strange happened at Mass General. You may have to come just to do research. Past 2 years, the percentage of intravascular guided PCI at MGH Boston, not Japan or Korea, is 85%. And FFR is 40%. So something happened.
Something happened.
I don't know exactly what happened.
I mean, I can tell you that anecdotally, the use of imaging in the US during the pandemic went up significantly because hospitals wanted to get the patients out of the hospital. They did not want them to stay overnight. Now, if that has any effect, I just don't know. But I know in Colombia, it's over 90% imaging.
I want to go back to the CT point, because what we see today is fairly focused on the diagnostic phase. You have a patient, chest pain comes, you get the plaque image by CT. But I think the potential of CT today for PCI planning is huge. So CT is perhaps the best modality to inform you about the presence of calcium, the severity of the calcium. You can measure the arc very precisely. You go into the procedure prepared of what you're about to do. And we're running a large randomized trial on that pre-planning aspect of the PCI that sometimes we don't have, because you just go in the case, do a few shots, and sometimes you have to do the PCI immediately. So this is something that perhaps in the future will certainly be a competency of the interventional cardiologist to understand how the CT helps plan and guide PCI.
Quick question. We do a lot of CT in Boston, but do you do additional CT just in preparation of PCI?
Yes.
Oh.
So I have to say that in our center in ALS, the CT has penetrated the cath lab in a way that I have seen colleagues stop in the diagnostic procedure, ask for a CT, do the pre-planning, bring the patient back. This is where we are.
I mean, there are some cath labs that have a CT in the lab. It's,
And I assume then you will do additional intravascular physiology and imaging.
Yes, if you think that the patient needs it, yes, of course. We are also, our penetration of FFR is, I don't want to say 100%, but we do a lot of FFRs. And yeah, all patients get at least a physiological measurement before deciding, and we are adopter of imaging as well.
No, the more data you have, the better you will be prepared. I'm not asking that, but asking is, isn't it too much? The radiation, contrast.
Well, I think that, you can derive physiology today from CT as well. What Jim shows today is just the binary ischemia and ischemia, but when you look at the FFR CT and you look at this fluid dynamics evaluation, I think you learn a lot. You can detect diffuse disease, you understand where the pressure drop is located, you can even do virtual stent with the new FFR CT planner. I think we're just starting to understand that we have a lot of information that can impact clinical outcomes, and we're learning how to combine all that information, including physiology and imaging, to see what is the best way forward.
I have one question to the physiologist. Actually, the low penetration rate of the physiologic study in the everyday PCI procedure, that I imagine that even in the technician in the Asan Medical Center, when they look at the angiographic appearance, maybe they predict that the similar value of the FFR without the use of the pressure wire. What I mean is that the 10, 15 years experience, what do they do? The beginning and the 15 years later, in the expert look at the angiogram, okay, that might be and the others, we have some treadmill test and the symptom, and the very tightest narrowing, we do the pressure wire in that case, just deploy it, that's it. So that is one of the reasons why we do have so anyhow, based on the physiologic study, the lesion looks like some undetermined, do or PCI or not. In that cases, we do a physiology test. Clearly clarified what is the characteristic. But very tight is narrowing, why we do a physiology test? It's clearly because we already learned from our PCI career and long time. So that is why we do so far.
Yeah, I think we do a lot, right now we are doing the defined GPS, and everybody in the GPS arm, they have to do pullback by IFR. And there is a lot of supplies. Like LED, you think the mid LED is superfocal lesion, but when we do the pullback, it's actually diffuse disease, vice versa. So I think we learn a lot, whether treat or not, based on the distal FFR or IFR, but how to use the distribution of the pressure loss is actually we're still learning. That's my feeling. And also the post-FFR or IFR, we learn a lot by looking at each case. That's, I think, we should learn more, even the 10 years experience for the FFR.
Yeah, I have one lesson from the physiologic study was that before the publication of the physiologic study, maybe we have more over PCI in some cases. But physiologic study, we have to let it alone. And then when I look at the intermediate lesion, and we do not physiologize, just let it alone. And follow up, and wait for some disease progression or something happen. And at that time, we do decide what we do. That is maybe everybody have a similar feeling about it.
I'll make a
maybe, go ahead.
Oh, thank you, Dr. Hu. A couple of comments. One, I agree completely that we probably don't need to be doing physiology in every case. Acute coronary syndrome, culprit vessel, we don't need it. Single vessel disease with a good abnormal, non-invasive stress imaging study, we don't need it. So yes, the penetration shouldn't be 100%, I agree. I would push back a little bit on intermediate lesion, we'll just leave it and watch, because we have learned that low FFR or non-hyperemic pressure ratios do predict higher event rates, even in asymptomatic patients. So I think, and also, plenty of studies have had expert angiographers try to predict the physiology, and they do very poorly, particularly in left main. So I wouldn't say that just because it's an intermediate lesion, we can sit there and watch it. I think we still need to use it in that setting.
Dr. Hong gave us the very important question, that issue that I fully agree with Professor Hong's comment, but we have to see the real world, what practice is in the real world. Actually, in Korea, as far as I know, more than 50% of PCA was done in non-academic hospital, small hospital. So in that hospital, I observed a lot of stenting procedure that looking very intermediate, very mild, but they put the stent every day. So in academic society, very well-trained operators, and Dr. Hong already learned from a lot from the physiology study. Dr. Hong did not put the stent in the intermediate stenosis, medical treatment enough, but it's not the real world situation. So I want to empathize that before putting stent, particularly in the mild intermediate stenosis, the FFR measurement is just the minimum requirement for good PCI intervention, I think. Thank you.
Yeah, and so the last comment from Antonio.
I have a question. How do you see using IVUS for decision-making to treat? I see many young people do FFR, the FFR is 85, 84, then they do IVUS, and they see a lot of plaque burden. A cross-sectional area is 3.8, in the LAD, FFR is not abnormal, but there is a lot of plaque burden. I think we should. Is that correct? How should we do it IVUS at all to make decision making, or should only use FFR?
So I'm going to turn that over to Dr. Koo, because he had.
Yeah,
basically that's the flavor trial.
Yeah, that's what the flavor trial is. So the intermediate stenosis, so physiology versus IVUS. IVUS has a PCI revascularization criteria of 3 square millimeter, or in case of 3 to 4, 70% plaque burden. So the bottom line is the outcome is exactly the same. But if you use IVUS, you're going to use more stents, more devices. So that's the answer from the flavor trial.
Yeah, and on top of that, optimizing the stent at the end of the day.
Yes.
Okay, so this is, SJ.
And Dr. Koo's flavor study, actually, we have to know that the IVUS minimal lumen area actually cannot predict any FFR. But for focalized, localized limb main disease is another story. However, in epicardial arteries, lots of factors to influence the FFR. And so minimal lumen area absolutely cannot predict FFR. However, in your study, you compare with the IVUS MRA and FFR, exactly same with the angio-guided PCI and functional FFR-guided PCI. That I agree that point, right? However, we cannot compare IVUS, just minimal lumen area and FFR. And to treat or not treat, absolutely we have to depend on FFR. However, any optimization concern post-stent, okay, we can do the IVUS. However, in your study, I really agree that on. However, IVUS guided is exactly the same with the angio guided versus FFR guided. Thank you.
So if I may add one minor comment is that in that study, when we designed the study, we didn't we had no intention to compare the imaging versus physiology because we understand that what is the prognostic element in patients, and I think that hemodynamic significance, luminal narrowing, degree of plaque burden. So that's how we designed the study. But I fully agree that the physiology cannot be accurately predicted by the anatomy.
Yeah. All right, so we're out of time. And there's another session to follow. Thank you very much.